to surgical and medical management, and then just prevention, right? Prevention's always much easier than treatment. So being aware of what those complications are, how to avoid them, and the post-operative considerations. And any of us that have dealt with complications for years, it drives wisdom, and wisdom comes from experience, and experience is often a result of a lack of wisdom. So obviously you learn from experience with this, unfortunately. So why do complications happen with plate fixation? A number of reasons in the horse. We're often working over the limits of our implants in horses. And so really it's only been recently that we have almost implants that will withstand those mechanical implications of fracture repair. Compared to DCP plates, we have much stronger plates and thicker plates for the horse, fortunately. But we still deal with sometimes with implant breakdown. And many times it's because of a poor understanding of the mechanics. So very important, if you're going to do plate repair in the horse, understand the mechanics, compression, tension, torsion, shear, and bending forces that we have to deal with in fracture repair in the horse. Sometimes these things happen because we're not paying attention to the details, right? Super important to be paying close attention to details in orthopedics when we're putting in plates like this. Wounds, probably 40 to 50% of our fracture repairs are subsequent to wounds, injuries, trauma. And so often we have an open fracture, and those are much more complicated, and we deal with much more frequent complications. And so this is just to give you an idea of what we deal with in horses compared to dog surgeons and human surgeons, right? So the people that fix fractures in humans have for clean surgery, so non-contaminated, 1.5% infection and a roughly 5% infection in contaminated wounds. But that goes up only slightly in the dog, but then we jump to much, much higher in the horse, right? Again, because our horses live in stalls, there's very little tissue over the implants and the fractures. And so it really jumps up high. So pretty much if you have a horse that comes in with a fracture that has a wound, consider it infected until you get far down the road. Also, why do some of these recovery complications happen? Well, because they're horses and they do things that get them into trouble in the first place. Often we have to help them recover. They're flight animals, so recoveries can be somewhat interesting and thrilling, unfortunately, in our fracture patients. And then unfortunately, our horses always have to evenly bear weight. And this is such an interesting complication when you're trying to explain to the public in our equine fracture repair cases why it's so hard. Not only do they get infected, we're dealing at the highest level of mechanical ask of our implants, but then the whole support limb laminitis thing, right? So support limb laminitis, that is a very frequent complication as well that we have to deal with, and always considering it from the very early stages of fracture repair. So how can we understand these going forward? So case selection is often about case selection and choosing the appropriate thing to do for the fracture that you're dealing with. Think about stability, good basic principles, good pre-planning, efficient intraoperative and preoperative approaches, and then think about antibiotics, however you can deliver them systemically. Locally is much, much better now, and into the incision. Any way I can deal with delivering antibiotics will help decrease my complication rate. So pre-surgical, draw the line, how I think it is based on the radiographs. Again, CT, having a CT really helps clarify. And then always think about your soft tissues, because if you treat the soft tissues right, we say they'll treat you right as well. So this would be an example of a P2 fracture, lots of different configurations, especially when they're comminuted, but that becomes much more clear when you use a CT to actually depict your radiographic lines. And so if I can do a CT, I'm never sorry I did a CT prior to a fracture repair in anything that's comminuted or the least bit complicated. This would be a comminuted P to fracture. And again, it changes from the proximal aspect to the distal aspect of P2, and it really helps guide where you're going to put that screw, so you don't put it through a fracture line and you get maximal stability. And then again, think about the wounds that are almost, often frequently there 40 to 50% of the time. That's always going to complicate things and make you have a higher risk of infection. And again, the bigger the wound, the more the higher the chance of being contaminated and having a long-term infection. And in these fracture repairs where there's a wound, obviously here an olecranon fracture, we have gas and contamination into that. And then we also, on top of that, have to do fairly large incisions to repair these, right? So that's greater time, that's greater invasion, and a much higher risk of having to deal with infection post-operatively. So orthopedic infection is those two words are the orthopedic surgeon's worst nightmare. Because obviously your case then probably triples in what the costs are, and logarithmically goes up with the complications that you have to deal with. So it can be infection, it can be expensive, and decrease your prognosis by quite a bit. So think about too is none of us obviously want infection to happen, but if you're suspecting infection associated with your fracture repair, and it's been a couple of days and it's looking every day like you're thinking your case may be infected, in the words of Dean Richardson, if you're fairly sure, you can bet that it's infected. And so just always think that it is until proven otherwise, because waiting can really put you behind the 8 ball in treating infections. So a little bit about the bacteria, they rarely are intracellular. They divide and they migrate up the canalicular system in the bone. And so that makes these infections very hard to deal with. And those bacteria hide within the bone, and it's a great place for bacteria to grow. Also, on top of that, bacteria like to form a biofilm layer, and that biofilm layer often makes orthopedic infection become a surgical disease, because you can only remove it by curetting out the infection or removing the implants. So consider that in terms of when you're dealing with these orthopedic infections. The biofilm is very hard to penetrate, and so often we have to remove that biofilm by curettage or by removing the implant, or both. Think about open and closed. If you have an open fracture, you're going to deal with infection to some degree almost universally. When you have instability, you deal much more with things like support limb laminitis, because instability makes them sore. And then think about, again, in the horse, especially in distal limbs, we have very little soft tissue and vascular integrity. So dealing with that makes these complicated. Remember, surgical time, tissue, trauma. I had a mentor in my residency that would say time, tissue, trauma. If you have a lot of trauma, you have time, a lot of time that it takes to repair that. Time, trauma, trash, right? So you're going to end up with a much higher degree of infection the longer that horse is in surgery for. So stability, surgical time, and experience all affect this. And then open versus closed. Open repair obviously is more straightforward. Minimally invasive is less ability to expose the tissues to open environment, but it's more difficult. So it takes some time and experience to repair them that way. A little bit about antimicrobial delivery when you're dealing with infections is that, again, prevention is the best cure, right? So if in human surgery, they've looked at the levels of antibiotics and the amount of surgical site infections. And so if you can increase your amount of antibiotics at the time of surgery, you're going to lessen the incidence of infection. And that's been shown in a study like this. And so think about maximizing your time preoperatively and intraoperatively so you have the highest amount of antibiotics to fight that infection that you probably have in there, especially if you have an open fracture. This was a paper out of Penn where they looked at long bone fractures and arthrodeses treated by internal fixation, 192 cases, and they had an infection rate of 28%. And those things were influenced by fracture classification, so more comminuted, higher incidence of infection if they were open, and if surgical time went over 180 minutes. All those things led to higher rates of infection. So think about that in terms of when you get to the post-operative period, what kind of fracture it was, how long that horse was in surgery, and what kind of soft tissue damage you're dealing with. Okay, clinical signs. I mean, some of those things I think are obvious in terms of lameness, fever, increased swelling, and then things you can monitor besides the really important clinical signs would be fibrinogen and then SAA. SAA has been a very important biomarker for us monitoring infection, and I've actually come to rely on it quite a bit. Surprisingly, when it first came out, I was a little bit, I think, critical of it, and then I've had some cases that have really convinced me, use SAA. It's a fairly cheap biomarker. You can do it stall side. You can get quick results, and it's a great diagnostic to have in your clinic. This is a serum, the SAA, for one of the first papers that came out, just showing that it is a very good acute phase response protein. And then this is another paper that showed the serum SAA in horses that had LPS injected into their joints. Often when you're getting to that point, you would rather not have to do an MRI. It's on a case that's already, you spent a lot of money on. Make sure if you get a culture that you do a sensitivity, and that can really make the difference between survival and death. Because if you can get the right antibiotic to treat your infection, you can quickly turn that case around. Sometimes we don't, and that can be very detrimental to the success. So aspiration as usual, and then if you have a pocket, you want to drain that pocket right away, because that's festering, that's multiplying the antibiotic or multiplying the bacteria in there. So drain it as soon as you can, and sometimes you can save them by that. So some diagnostics here. And again, if you can get a bacterial culture, it can really help guide you. Just because one thing to keep in mind, however, is just because you culture one bacteria doesn't mean you have a couple of others in there as well. So if you're having some success, but not universal success in treating your case, it may be that that's only one of your bacteria that is associated with your infection. Okay, and then this is from, again, the Ahern paper out of Penn, where if you have more than two things, such as positive culture, a draining tract, radiographic or ultrasound evidence, more than those two things, then you have a very high risk that your fracture and your implant is infected. Important to decide if it's superficial, because that's easier to deal with than deep. And of course, once your bone is infected, once you have osteomyelitis, that becomes much more difficult and expensive to deal with. So this is a case that was a fracture repair of the proximal tibia and had just a sub-Q infection that was managed quickly, right? But that could have gone the wrong way if it wasn't acted on quickly. Deep infection, when you start to get osteomyelitis, well, that requires often removing your implants, replacing them, very expensive. So you'd rather not deal with it when it gets to that point. Drainage and debridement is key. Removal of fluoxetine can cause vasculitis, but leaving that catheter in there and then delivering your antibiotic for roughly 20 to 30 minutes will allow you to get much, much higher levels of antibiotics locally. So it's a good way to deliver antibiotics. Regionally, some have used intraosseous perfusion, not quite as, not used that much really, because by this time you're putting another hole into the bone. So, but it is a way to deliver antibiotics if you're desperate. And then of course, intra-articular if you have an articular infection as well. PMMA is a great way to deliver local antibiotics around the plate. So we have a little bead maker that we use at CSU. So we put polymethyl methacrylate in there. We put antibiotics in there when we're making up the polymethyl methacrylate, and that delivers high levels of antibiotics up to about 6 weeks. So it's a nice way to deliver antibiotics, and also you can lute the plate, so you can put it around the plate as well. And it's a nice way to deliver all kinds of different antibiotics. And we utilize it quite a bit in infection and then in preventing infection as well. You can use plaster of Paris too, but the antibiotic doesn't stay around very long. Plaster of Paris sort of disintegrates after about 5 days or so. So you get a high rise in antibiotic release, but then it goes away quickly. So I like using PMMA better because you have a longer release of antibiotics locally. All right, what about other things that cause complications? So we talked about infection, spanning a joint, immobility and cycling, and technical errors. So I'll just run through some of these. Infection we've talked about and how to treat, but think about, again, this is a fracture of a jaw. Almost always, 99% of the time, they're going to be open, right? Because the fracture goes into the oral cavity. So plan on that being infected. It doesn't, you can still manage these, and with locking plates, you can still manage these, and it will stabilize for a while, but plan on this being infected. So, and this is also highly cycled in this type of situation, right? It's a mandible, it's open, and the horse is going to eat. So there's going to be high cycling in this case. If they span a joint, this was a case that came in, it was a long story, but we had to put a plate over this to stabilize it further. So I knew those 2 proximal screws were going to get loose fairly quick, but hoped that it was going to provide enough stabilization for at least the bone to get there. But mobility and cycling, spanning a joint, will increase your loosening that happens with your implants. This is a case that was interesting. This horse had this fracture for 8 months. And so they rushed it right in. And then this fracture repair was challenging because there was a big loss of bone. So there is a deficit of bone that led to, having a loss of bone across where the fracture line would have been had we been able to repair it right away. But it stayed stable enough for that horse to become sound. But I knew those screws were going to eventually break as that horse cycled it more. So they did break at the fracture line, but it stayed stable enough for that horse to eventually heal that fracture and become sound and ridden again. And then technical errors can happen, right? They're long surgeries sometimes. There's sometimes a loss of focus, and little things get missed. So remember that when you're dealing with intraoperatively some technical errors. This is a case that end of that plate, right? Because we only have 1 screw across it, because we can't extend that plate any more distal, or it will interfere with the P3 extensor process. And so the end of that plate should have been closer to the bone. This joint did go on to fuse, but you can see this distal screw eventually broke, which you'd rather not have that happen, especially if you had to take the implant out. This horse ended up doing fine, but a technical error that probably could have been prevented if a little more attention was paid to where that plate was ending and how far away from the bone it was. Okay, so I'm just going to quickly go through some management and prevention of these things. How do we deal with the mobility and cycling and spanning a joint I never ever used dynamic compression plates by themselves anymore. I actually haven't taken one out of the pack for a number of years. We exclusively use locking compression plates, and they have been a lifesaver for our fracture patients. They're much more stable. They're more expensive, but they're worth the money because your fracture repairs are much more stable, and you decrease cycling on your implants by using locking compression plates. So that's universally what we use on all of our fractures now, and that has been a big game changer in equine fracture repair. Technical errors: beware of the common mistakes that are made. Be diligent in surgery and use imaging as much as you can intraoperatively. If you have a fluoro, that's even better, although there are some tricks with fluoro that you have to be aware of. So things like that, look very closely as you're looking at your implants and the length of your implants to make sure that it's perfect. Because if it's not perfect, you'll know soon enough. Poor recovery, we deal with that again in our flight animals, and ending the plate mid-diaphyseal. So this is a arthrodesis of the middle carpal joint and the carpal metacarpal joint. This horse fractured in recovery because even though those plates weren't ending at the same place, it was long and ended up in the mid-diaphyseal region. So these are complications that can happen. Now we go to using much shorter plates when we do carpal arthrodeses that have led to much more success. This was a horse that had many years prior to presenting had a pastern joint arthrodesis and was acutely lame, and because that plate ended up being fairly mid-diaphyseal and needing this repair. So think about that when you're thinking about where your plate is ending. Again, we're often exceeding the mechanical limits of our implants, and we need to take care of our soft tissues, right? This is a horse that was not that dislocated when the fracture happened, but the horse trailered to our clinic several hours, the cast broke. And so you can imagine the soft tissue damage that would be associated with that, right? And so that horse needed to be euthanized eventually. And on the left is the deep digital flexor tendon that was completely torn apart because of the dislocation that happened on the trailer ride because the cast broke. So how do we deal with some of the poor recoveries? Unfortunately, we don't have a pool at our place, but something I've gone to quite a bit that I've been very happy with. It takes a team that gets comfortable with it, but sling recoveries, this is an Anderson sling, and these slings are amazing, actually. They have saved a lot of horses on recovery, and I've been disappointed sometimes when I haven't reached for it when I thought I should have. It takes usually about 4 or 5 people, to do these recoveries with the sling, but when you get good at it, when you get a team that's comfortable with it, it's the very nice way to recover horses as opposed to head and tail ropes if you don't have a pool. So we use that quite a bit. Don't end the plates mid-diaphyseal if you can help it. Again, exceeding mechanical implants. If you think you might need 2 plates, use 2 plates. Because you'd rather one more plate while it ends up being more time, more expense. What you would hate is if your implant failed because you didn't have enough in there. Okay, and then last few slides, I'll just talk about my most hated syndrome is contralateral limb laminitis. On these horses that we do these extensive fracture repairs, they get to the point where they're almost there and they're healing, and then they get laminitis. And so at our institution, we looked at a number of horses over a period of time, how common support limb laminitis was. And of course, there was about 12 to 15% incidence of it in horses that had casts on. The bigger the horse was, the more advanced procedures that were done all increased, and the weight of the horse all increased the incidence of it. So it's something, unfortunately, that we all have to deal with. In foals, they don't get contralateral limb laminitis, but they do get laxity, right? So if you fix an olecranon fracture, this is an olecranon fracture in a foal, that had been presented several days after, and it started to get very lax on the other side. So don't ignore that, because you can fix the fracture, but then lose the case because you're not paying attention to the other limb. So as you can see, I could push that in from laterally and correct it, which means that the collateral ligament was fairly stretched. And so we splinted that to help that baby. ALDs happen. This is a long chronic case, courtesy of Dr. Richardson, that had a very successful femur fracture repair, but ended up having a horrible angular limb deformity. So don't ignore the other side and keep that baby comfortable no matter what it takes, or you'll end up with that. And contracture also, right? So contracture often is something that happens because they're not bearing enough weight on the fractured limb. And so you need to do whatever it takes to actually make them bear weight on that and straighten the leg so they don't get contracture on the affected limb. Okay, so for foals, the contralateral limb, prevention and management is your best treatment. Keep them comfortable, keep them stable, use splints, use toe extensions, whatever it takes to keep them straight and supported. And then how do we manage contralateral limb laminitis? Still not well. I feel like we've gotten better and done some things that have helped these cases, both diagnostically and treating them more aggressively. One thing I do whenever I do a fracture repair is always make the other limb, the contralateral limb, even. If they're even, it decreases the amount of either the affected limb or the contralateral limb being overweighted. And so some people will use clogs to make them even, but when you put a cast on, you have to balance out the other foot by elevating them and making them even from left to right. Super important. One thing we've gone to is these Nanrick Ultimate shoes. It makes them even. You can build them up if you need, but it also increases the angle of the heel and decreases the pull of the deep digital flexor tendon. And so I really have gone to that based on working with a lot of podiatrists that recommend this, and it's really been helpful in managing and decreasing the incidence of support limb laminitis. This is what it looks like. So you look at that and you're like, whoa, that's very high angle. But again, decreasing that pull of the deep digital flexor tendon is going to help decrease the incidence. This was a case that was a transfixation cast that was in a Nanrick on the other side. And so we increase or decrease the mechanics, whatever it takes, to again make them even with the shoe, but decrease the pull of the deep digital flexor tendon. When we're not sure, we'll do a venogram on these horses. And I'm learning a lot about how to interpret venograms because it's not something I did much throughout my career, but I'm getting more and more comfortable. This would be a fairly normal venogram, but they really get compromised. And managing laminitis is about managing the vascular supply. And so we will do venograms if we think the horse is in trouble. And I'm much more aggressive about doing a deep digital flexor tenotomy on these horses if we need to. So if we're losing the battle, and you can see in this, don't have a pointer, but you can see in this radiograph on the right, the P3 is starting to extend down below where the vascular supply is on the foot. And that is an evidence of decreasing vascular supply there. So we're much more aggressive about doing deep digital flexor tenotomies because you can save a lot of horses and they can come back to being athletes, which is always often something that people think that's not possible, but they will, and their tendon can heal and they can go back to some level of performance with that. So that's something we do much more aggressively. This is a compromised blood supply venogram that we would do some different things with mechanics first of the foot, and then if we're still losing, pursue a deep digital flexor tenotomy. But you can see the vascular supply via the venogram here is compromised on the dorsal aspect of the foot and also at the toe. So this is what we do when we do a deep digital flexor tenotomy. We work with the farriers to put tenotomy shoes on there. So when you release the deep, you actually have to support the bottom of the foot and give them some support so they don't subluxate the other way. But we've been able to manage some horses successfully with that. And I'm learning a lot about this technique now, and something we've added to our armamentarium of treating these horses. So that's complications at warp speed. But if you think you may have a complication, face it and don't stick your head in the sand, because it only leads to suffocation. So that's what I like to tell my residents, and face what the thing that you really hate and don't really want to deal with. But the faster you deal with a complication like infection, like implant breakage, then the better you're going to be in terms of being able to manage these cases. So face it and fix it, and then move on. And a favorite quote of mine, Winston Churchill: "Success consists of going from failure to failure without the loss of enthusiasm." And Sue Dyson told me this a long time ago when we were on a ski lift, that equine orthopedics is not for the faint of heart. And I fully agree with that. So take home messages: adhere to basic principles, pay attention to the details, be familiar with the common mistakes prior to starting out on some of these bigger procedures, face your suspicions and act on them. And then AO, which I am proud to be part of and proud to be part of teaching, has some amazing educational webinars. So join AO. They have great they have great lectures on there and learning modules. Wonderful way to learn more about equine fracture repair. We're all students seeking knowledge. I love teaching for this course because I learn a lot from my colleagues as well. So thanks for your attention, and be happy to answer any questions.